Welcome to the Scale Healthcare Technology and Innovation Podcast, where we explore how innovative technology is revolutionizing U.S. healthcare. Hosted by Jason Schifman, President of Scale, we sit down with industry leaders to uncover the strategies, breakthroughs, and technologies shaping the future of care. Join us and subscribe as we dive into the cutting edge of healthcare innovation.
All right, welcome to our next Technology and Innovation within Healthcare podcast. I have the pleasure of being joined today by Barbara Wachsman, and it's a special treat when you get to dig into an area that is new and bring light to it, and that's exactly what we're going to do today. Barbara brings 25 plus years experience in all things in the employer market, from large-scale companies to networks that have brought executives in the HR and benefits arena to innovative companies together. Barbara was the director of strategy and engagement for enterprise benefits for the Walt Disney Company, overseeing their national benefits program and helping to structure and execute on some innovative initiatives that we'll dig into. Prior to that, Barbara was a senior executive at two international benefits consulting firms, and she was also a principal at Arthur Andersen in serving large employer clients with their healthcare benefits programs, and she's done a number of other things over her career. So a really rich conversation today exploring the employer healthcare market, something that we hear a lot about, but oftentimes know very little about, at least on the provider side of the equation. And so we look forward to a deep dive discussion today with Barbara, covering a lot of ground. So welcome.
Yeah, great. Thank you. I'm looking forward to the conversation. Heaven knows we have a lot to talk about in healthcare today.
We do. So why don't we jump right into Walt Disney, and then maybe we'll zoom out after that and talk about the employer market. But what went on at Disney? What did you build? Why did you build it? And what did it look like?
Boy, how long do we have to talk? Because it was created some really interesting things that I think are directly applicable to providers and things that we can think about doing in the future. I want to add one thing when I talk about my background, which I think will make the people that are listening to this podcast have some trust in what I'm saying. And that is I've also worked on the provider side, and I come out of the public health world. I've worked in large hospitals. I really understand providers, and I think that they are really the cornerstone to the delivery of healthcare in this country. So just want to put that out there and hope that makes people feel a little more comfortable as they hear me talk about how much employers and payers are struggling with the cost of healthcare today. So Disney, I went to Disney having been a benefit consultant for many years, and finally had a chance to go what we would call to the dark side, to an entity that paid almost $3 billion a year in healthcare, 200,000 employees, most of whom are minimum wage workers, highly unionized environment, and folks who are getting sicker and not healthier with the benefits and the healthcare delivery that was being provided as I arrived at Disney. We had such an opportunity because of the leverage that we had in the healthcare marketplace to really change that. So at one point, we decided to take a really deep look at our healthcare costs and realized really the trouble that we were in as a business enterprise, and the impact that it was having on our ability to really run a profitable business with the costs that we were paying for healthcare, as well as the poor productivity of our employees, the poor health risk of our employees. We took a look at our various markets and uncovered the fact that in Orlando, where we had 60,000 lives, again, great leverage in that marketplace, that we were paying 30% more than any other market in the country for Disney. So that included ESPN in Hartford, that included New York, that included Los Angeles. In Orlando, paying 30% more than any other big urban market in the country. And why? Because it was a very uncompetitive market with two very expensive hospitals. And I think at that point, we realized we really did need to do something different and decided to make some very big changes. We decided to do a direct deal with the two large hospitals there. We wanted it to have features that we thought would really change the dynamic in the marketplace. And by that, I mean really aligning incentives around risk. And ended up having a deal, again, covered about 60,000 lives, full risk up and down. Today, this deal now has been in place for 7 years. More importantly, the physicians are making money, the hospital systems are making money, and the Disney employees really love it. I've never been a part of anything else in healthcare where all the entities were actually happy and working together. And this was because the payment system was really aligned. Providers could get rewarded for taking care of Disney employees and eventually making them healthier and having a more productive employee. And physicians could practice medicine the way they wanted to practice. We can talk a lot about as we go into more detail about this, but we can talk a lot about some of the specific things that happened during setting up this deal over a 2-year period. Having physicians tell me to stop talking about healthcare in California, for one, to fine, we'll stop talking about healthcare in California. We'll talk about healthcare in Florida, which is unique in its own way, talking about hospitals that were very reluctant to enter into this deal with us. But we actually told them this was not going to be a question of whether or not we were going to do it. We were going to do it. And actually at one point said, if you don't do this deal with us, we will reduce our benefits. And what would you prefer to have, more bad debt, or be able to do something with us that will, and actually the statement I got from the CEO of Advent, who was one of the hospitals, said, look, we're going to have to learn how to do this for Medicare, so we might as well learn on Disney. And I said, that's absolutely fine. So that's kind of the rough parameters of that deal.
So for those of us that are less familiar with striking a deal, you said we did a deal with the hospital, the 2 hospital systems. So I imagine, was Disney a self-funded insurance prior to going into the deal with the 2 hospital systems?
Yeah, absolutely. And we can talk a little bit about kind of the self-funded marketplace. So yes, Disney was and is self-funded. And in fact, most employers over about 500 employees in this country are self-funded.
And so,
go ahead.
So the change basically was at prior to the deal, Disney was taking full risk on their healthcare as a self-funded plan. Pro forma for the deal, Disney's still taking full risk on that plan, but you've shifted the care delivery, and B, you've subcontracted that risk to the health system. Is that a fair summation of what doing a deal with that hospital system looks like?
Yeah, I think that's a good way of putting it. Ultimately, the self-funded employer is the health plan. We are paying for the care that's delivered to our employees. That will be the status from now until whenever. I mean, that is the way healthcare is delivered on the commercial side of the world today in healthcare. The way it has been is that we were pretty much of an order taker in terms of how much that care was going to cost, the impact it would have on our employees, with the carrier as a middleman, determining how much providers would be paid, how they would be paid, how medical management would be delivered. And we were very unsatisfied with how the carrier was managing the healthcare of our employees. And we decided to step in and do what we call a direct deal with providers and cut out the carrier in the middle. So yes, to your point, we were and will always take ultimate risk, that is the cost for delivering care, but we want to have a direct relationship with the supplier of that care, that is physicians and hospitals in the community who are taking care of our employees, and be able to say, we'd like this and not that. And up until doing this deal in Florida, we really weren't able to do that.
You felt by building your own network or entering into this committed partnership that you would do a better job on your medical loss ratios or your average cost of total care, so that you as the health plan, your cost would come down. Is that?
Yeah, I think that's a good way of putting it. I think what we wanted were providers who could interact directly with our employees and deliver care the way they wanted to deliver care. We were not going to tell them how to do it. We weren't going to say, we want to insert a certain type of medical management. We said, we believe in you. Physicians and hospitals in Florida know best how to care for our employees, and we are going to pay you what you deserve to do that. And we are going to be hands off. We're going to reward you if you could meet that budget that you've agreed to and meet those quality standards that you've agreed to, we want to reward you. We are the purse, if you will, willing to pay for great care delivered to our employees. It will produce a productive employee. So it is a little bit of, we are the health plan, but it's a little bit different than the carrier, for example, who is going out and renting a network for us, if you will. We felt that we could give the network the data, they would know who they were taking care of, and we could set certain standards together in partnership and say, this is the kind of care that we'd like to have delivered. We have medical directors that actually we have on our staff at Disney that work directly with the providers and coming to a common agreement about the kind of care that we'd like to see delivered. And then we want you to practice medicine the way you want to practice medicine and deliver on these performance standards, basically around cost and quality.
So if I'm an employee of Disney, if I'm an employee of Disney in Orlando, from executive all the way down to the staff level employees, if I want to go to an in-network provider, I'm going to an Advent or this other hospital system, a provider from their network.
That's right.
So you brought a lot of volume you brought 60,000 lives to these health systems. So they're saying thank you for the volume. In exchange, they're going to commit to providing comprehensive, coordinated care to your in a much more organized manner to your 60,000 lives.
Jason, you're putting it in a much more articulate way. That is exactly right.
What does organized care mean? Is it they agreed to provide care monitoring? Is it remote patient monitoring? Is it benefits design? What does that sort of organized care look like from a structural perspective between Disney company and the hospital, between Disney employees and their benefits plan with the health system?
Yeah, so I'll take a little bit of a step backward. I think what we were really interested in was making sure that the incentives for affordable, high quality care were in alignment. We wanted to make sure that the providers were responsible for delivering a certain level of care to our employees, and we wanted to pay them for it. We wanted to reward them for it. So to go in and say, first and foremost, we'd like you, and using the word risk sometimes can have a negative connotation, but we wanted you, the provider, to be accountable and to take the risk for providing care to our employees. That was first and foremost. The only way you can do that is to make sure that the providers know who they are responsible for and that there is true attribution. The only way you can do that is to have a benefit design where the employees have some skin in the game. The employees go in and say, I am going to go to this primary care provider for the next year for anything and everything I need. And I'm going to rely on that provider to send me to where I need to go, to not send me to where I don't need to go, to take care of all of me. So we did have a benefit design that required the employee to select a primary care physician. And then we were able to say to those physicians, here is your group of employees. Here are, for each hospital system, there was about, 30,000 employees plus their families, which adds another average 2.2 people to that group. They are your people to take care of. We're all in agreement as to what the budget will be for that because we have 20 years of claims that we have paid you. We know when it what you need to charge us to deliver care, and we're going to give you an increase on top of that every single year over inflation. But we know what it costs for you to deliver care. We're going to pay you for that, but we want you to take responsibility for this person, everything that there is that they need. We talked to the physicians about wrapping their hands around our employees. So I think having those tenets in place, that is, you deliver good care, the care you know how to deliver, and we are going to deliver to you the volume of patients that's going to allow you to make some money, quite honestly, as you take care of our employees. So it had those special tenets of value-based care, of risk, of data. We had more data than any of the carriers had on your specific services to us. We're going to tell you who these employees are, the demographics of every single person you're going to take care of. And trust me, Disney employees are older than average because we have almost no churn. People do not leave Disney. You'll probably see when you go to Disney World, there's 70-year-olds at the gate greeting you. This is not a good thing necessarily, but what that means is you have got that person for life. And if we are asking you to take care of all of them, that person is not going anywhere. But to your point, I think you were suggesting there has to be a plan design that supports that attribution. And by the way, we required every single Disney employee to select a primary care physician, whether they were in Orlando, New York, Los Angeles, it doesn't matter. We really believe in primary care. We think that everybody needs a health guide and should at least acknowledge when they go through enrollment who that person is they want to have take care of them. Now, some of those folks are in a PPO plan, which, the attribution doesn't matter as much.
Well, I wanted to spend a minute on this topic of selecting a primary care because it feels like you borrowed from the Medicare Advantage market where you are signing up for primary care and there is more formal structure for attribution. And that's a market where full risk-based contracting has proliferated in Florida in particular. So it's interesting because commercial markets haven't necessarily, at least my understanding, adopted that as much, but it sounds like Disney has cracked the code, at least in Orlando, on creating attribution and alignment with the primary care provider in the commercial market. So was that the case with all your employees in that market, or did they have freedom to move around to different primary care providers?
Well, having, and we could talk a little bit about employers. I mean, they're kind of an odd bunch to begin with to be delivering care, honestly. I mean, however that got set up however many years ago, I don't know. But yes, I mean, we had to offer choice to our employees. So in any given marketplace, they could choose a PPO, an HMO, they could choose a high deductible plan. Of course, there are costs associated with all of those. And frankly, the way we priced those plans, and we could drive employees into one plan or another. Disney employees, I think I mentioned the majority are minimum wage workers. We did survey work before we designed this plan. They will move for $1 difference in their premium. And physicians really need to know that. We did a survey at one point and asked our employees if costs went up, what would you do? Stay with your physician and pay more. Move health plans. What would you do? And I'd be curious to know what you think the answer was. 80% would move physicians. And I don't think physicians realize that. I think they think, oh, Barbara is never going to leave me. Not true. Employees are very, very sensitive to out-of-pocket costs. So we did have to give them choice, but choice was priced appropriately. And yes, it has many tenets as Medicare Advantage today, but we also made the deliberate decision to contract with a CIN, with an entire network of providers. So not just primaries. We would never work with this primary group where they're going to send people out to specialists that they don't know. We wanted to be able to contract with an entire system where the physicians all work together, where physicians can refer out to the orthopedist, can refer out to derm, can refer out to whoever they need within their system, and where they're all, hopefully they're all incentivized to work together as a system. We absolutely did not want this to appear that there was a narrow network, that there was going to be a limitation on care. And in fact, what we wanted to say, and, when we designed the benefit plan, we want you to get as much care as you need, and we want to price this so specialty care is built in. This is not about gatekeeping whatsoever. But we do think primaries have a role in helping employees do things like manage their diabetes. I don't think, an endocrinologist wants to have that diabetic who simply needs to work with a CDE to have some better nutrition. Send the people to the endocrinologists who are those brittle diabetics and really need their help. So the idea was really to contract with an entire system of care, including hospitals, and that's what we did.
One thing that's moving to sort of the execution side is, as an employer, given that so much of your expense is, or I should say that employee benefits is a big portion of your expense, you're in the healthcare market. And I think, it sounds like Disney was embraced that role and was proactive and innovative in addressing that role. What did it take from an operational side to take that proactive and innovative role? You mentioned data analytics, so it sounds like that was a core discipline that you had to build within Disney. But what other core disciplines were required, and what was the ongoing nature of the relationship between Disney and the hospital system? Were you having sort of joint operational meetings, or was it more arm's length? What did it look and feel like?
Yeah, that is such a good question. Well, just from an operations point of view, it took us about 2 years. We did everything. Well, I would just say this. We had an actuary on staff. We probably spent $1 million on consulting services. We do, and most large employers and jumbo, which is a whole subset of large, typically spend a lot of money on data warehouses where we had a lot of, 20 years of claims data, uh, great data analytics engines that we used, but we worked arm in arm with the hospital systems. We had governance committees. We had various operational committees that, could be meeting weekly. I mean, when these systems agreed to take risk for the large number of employees that they were getting, I think that's when they realized they really needed to get involved in the determining and designing the operations. And I will tell you one funny story. One of the systems, and this may be familiar to some of those that will be listening to the podcast. Hospital systems typically do not like the carriers coming in and telling them how to manage care. They don't like those nurses that go onto the floor and make judgments about when somebody can be discharged or not. There's kind of love lost between those two entities. Well, the system told us that and said, look, we really want to do that ourselves. We want to take care of medical management. We want to decide when somebody can come, when they can go. That's what we want to do. And we said, fine. And we're going to pay you for it. I mean, typically we pay the carrier about $12 PM for that. And we said, that is just fine. You take that on.
Mm-hmm.
About 2 months later, we had that hospital come to us and say, we really are not capable of doing that. And we said, great. Well, we'd really like it if you would learn how to do that, because that is critical to you being able to truly manage that patient. And today they do take responsibility for medical management. But I think what's happened is, the carriers have played such an unusual and weird role in trying to be a clinical plan. They are not clinicians. These are claims payers. So I think they realized they had so much to learn and so much that would help them under Medicare Advantage, for example. I mean, this was prior to MA plans getting so popular. But I think they were absolutely right in thinking we need to be, manage our own destiny, learn how to take on some of the services that the carrier does. Now, will they ever become a claims payer? Will they ever become a health plan? I mean, you see Sutter here in California trying to be a health plan, trying to pay claims. This may not be something that providers and big systems really want to take on. Some do better than others, but to be able to do all of the medical management that's necessary to get that productive employee, we are all for, and we will give you all the money it takes to do that. So, paying $3 billion a year in healthcare, there's a lot of money to move back over to the provider side. So let's see, I think you asked me about operations. We had, joint operating committees. This went up to the most senior parts of Disney. Interestingly, we did have several Disney executives that sat on the boards of the various hospitals. This was a conflict, and we worked through that, but Disney is such an important entity in the Orlando market. Disney sucks up 30% of the working population in Orlando, for example. It was somewhat difficult, some of the conflicts that we encountered. Many of the health plans and the hospitals buy or sell, we purchase advertising. And at that point, we really had to make the decision, are we more interested in working with them as partners in providing care rather than an entity who is giving us revenue to be able to advertise to our employees? So there were some interesting conversations, let's put it that way.
You mentioned,
yeah.
Yeah, you mentioned savings, so it sounds compelling. Is there a percentage that represent a 10% reduction, a 5% reduction, or?
Well, that's a really good question. It's hard for me to really think about. Let's just say we had savings when in fact every year we were experiencing about a 10% increase in costs year over year over year. So actually to reduce that, that increase and actually to absorb savings, it was just an enormous amount of the money that we were spending on
So
healthcare
quite
in Florida.
successful. So what
Yeah,
about
very much so.
the other 140? So 60,000 lives in Orlando, and those were the most acute, where you saw the cost, the 30% premium I think you mentioned
Yeah,
relative to these other markets. But
yeah.
did you apply lessons learned from this partnership dynamic in Orlando to other markets, or was it really unique to Florida for whatever reason?
That is just such a good question, because it also speaks to what we can look forward to in the future. So we did try to do that. We did try to apply those same principles in New York, for example, where we have ABC television, ESPN, theater, publishing, not 60,000 lives, but I think there were probably close to 20,000 lives. We approached Columbia Press and we got a resounding not on your life. I think, these are academic institutions that I think have other goals in mind. I think they're very happy with the position that they hold in New York. It was just difficult to be able
Is it a
to.
leverage dynamic? Because, in Florida, your 60,000 lives represent 30% of the market. In New York City, your 20,000 lives represent a much lower percentage. Or is
Yeah.
it culture of the hospital organization, or a bit of both?
I think it's a bit of both. We just didn't have the same reception. I think
Mhm.
also in Florida, we were able to use leverage because, we could reduce our benefit plans, we could do all kinds of things there. But in New York, it was just a very different setup. I think also the message we got loud and clear from these academic institutions were, we are not ready for risk. We like
Right.
submitting a claim, and we just are not ready for risk. And I think that was the bottom line, because they wanted to work with Disney. And what we ended up doing actually for our ABC employees was striking a deal with Cornell Weil, where they would be sent over to Cornell. The employees would first be sent over to Cornell for certain types of services. It's funny, Memorial Sloan Kettering had approached us and wanted us to give them all of our cancer care. I mean, we had an opportunity to kind of mix and match around certain services where we could strike a deal, have kind of a special relationship with some of the providers there. But it was more about the patient experience. It was more about customer service. It
Mhm.
was more about getting somebody in the door first, rather than actually having that holistic look where we're saying, you take care of this employee. We tried to do something very similar at ESPN in Hartford, and ESPN is a very different population. Young ex-jocks, basically, primarily men. So what we really looked for there was to try to find a group that had very strong OB, strong mental health services,
Mhm.
and it was very difficult to find a group that was large enough that could take the population there, even though the population was only about 10,000 lives. So there's a lot of that kind of mixing and matching what's available in the marketplace. How many employees do you have? Where are they currently going? Are you just going to cannibalize existing business? Are we giving you new business? I mean, we understand providers want volume. I mean, that
Mhm.
if they're going to take risk. So we did try this now in Los Angeles in Southern California, where we have about 25,000 lives at Disneyland. We were already working with very large full risk medical groups down here, and Kaiser, which is the other big gorilla in California. So we really didn't feel the need. Our
Mhm.
costs were good, the quality was good, and we really didn't feel the need to aggregate and to give everything to one particular entity.
It follows suit with where risk in general has proliferated. I mean, Florida, California, two markets where we see a lot of risk-based activity with provider groups where they've assumed the risk, whether it's a health system or meso. And it sounds like you had luck striking in both of those markets. Different structures. You didn't need to enter into the structured relationship that you did with Advent in Florida, but nevertheless, both of those markets lead in MA risk, and it sounds like
Mhm.
are good partners for employer commercial risk as well, whereas Connecticut and New York struggled.
Yeah, exactly. And I think, I love it, the value-based care, whatever that is, where you're asking providers to take risk. I don't want to say it's fallen out of favor necessarily, but it's really tough for certain groups to be able to take risk. I mean, there are things that you've got to have in place. You've got to have some analytics. You've got to, have tech. I mean, there are things that you need to be able to have in place to do well under a risk-based deal. I don't think employers are necessarily wed to risk. I think they just want the incentives to be aligned. And what that means is if you can help my employees become more productive, and that is the key now, then I am going to pay you for that. You can go ahead and submit claims, but if we can agree that if you do X, if you can get these people, for example, as I always say, we needed that person to drive that ride in Orlando. And if you can get that person, to lose some weight, to deal with their sleep apnea so they can meet that DOT physical that half our people couldn't meet because of obesity, I want to give you money for that. Now, there's a lot of discussion among employers. Should providers be rewarded for doing the right thing?
Mhm.
I do not care. I think if providers can help me get a more productive workforce, I want to reward them for that. I mean, it does take that investment in tech, analytics. You've got to have the right providers. You got to be able to take care of people when they need to be taken care of. I mean, we've got a 24/7 workforce. We need somebody to be able to call you up in the middle of the night and not go to the ER. I mean, people should be rewarded and be supported. And at different points, Disney was actually willing to do investments in equipment. There was a large medical group that was looking to purchase some new equipment. We were willing to actually go in and purchase that equipment with them as a partner, because labor costs for an employer are enormous.
Mhm.
And if we can keep people at work, FedEx, Disney, these are companies that overstaff by an enormous amount for people that are out. And having somebody back in that seat is actually more important to me than paying for a knee replacement, honestly. So, and if we can find providers that are of like mind, who understand, they really want to deliver great care and get somebody healthy, we want to partner with them. And I would say most employers do. But of course, it comes down to things like, do you have enough volume to make this worth my while, to do something special for you, Disney? And we had a large group across the street from the studio lot. The carrier actually was very opposed to us doing a deal with them. That's a whole other podcast. And we said, fine. Number one, we're going to have a side letter with you. Number two, what we really just want to have happen is when that executive over in the studio has a back problem, I want you to see him that day. And I want him to get to the front of the line because this person needs to be back over at the studio lot. And, if a provider can do that for me, we actually ended up, for that large medical group across from the studio lot, paying for a therapist to provide mental health services to Disney employees. We actually put a CDE, a certified diabetic educator, in their group, paid for it. They gave us the real estate, but paid for it because it's, again, more important than these people are back on the lot working. So finding finding an employer as a provider, finding an employer that has this need for a productive workforce, and you've got a partnership.
Yeah, I mean, I want to take a step back and talk about the employer market more broadly, and there are a couple graphs that I want to bring up and just get your thoughts on. But one of the questions we'll get to through that is, what's the strategy for companies that are not 200,000 employees big? Because clearly this requires a lot of resources between all that you described that you built internally, plus the specific programs, care programs, plus the commitment to buy equipment. That's relevant for the top 1% of the employers, but what about the rest of us? So with that, there are a couple graphs that I'll just share screen on, and I think they're meant to just give a little bit of an overview of the employer market more broadly. You alluded to some of these stats, and I just wanted to get your narrative on them in general. So the first is looking at who is self-funded. And so, as you mentioned before, the percentages are quite high for employers that are 1,000 and above at 83, 84%. They're quite low for the 50 and below, and then they step up in between. So maybe that's a good chance to sort of just talk about what does this self-funded market mean for employers that are in the 1 to 5,000 category, or even in the 2 to 900? Do they have an opportunity to do maybe not what Disney did, but something more innovative than from a benefits design or from a care cost of care management perspective?
Well, Jason, I understand why you're running the group, because this is the $64,000 question that everyone brings up. But wait a minute, we're not that big. We don't have that leverage. I mean, yeah, it is true that we had a very unique circumstance, not only a large number of lives, but a specific location where there was a provider that, could take care of all of these people and frankly had enough capacity to take care of all these people. That was definitely an issue in Florida. So, yeah, there are some special circumstances where you can do one of these bigger deals. But it is possible for employers, and many of them do this, that will come together as a group and then look to find a provider that's in their area. And I think we might have talked about this before in Silicon Valley, in San Francisco, a group of high-tech employers that have not as many domestic lives as they do global came together in the Silicon Valley area. They actually built an on-site clinic together that they could all use. And they do come and can, there are regulations that might prevent monopolistic behavior and all these kinds of things. I mean, they may have to contract separately, but they can work together strategically to say, this is what we want as a group. Come work with us. And that happens on a fairly regular basis where employers, perhaps through a coalition. The Pacific Business Group on Health, actually now called the Purchaser Business Group on Health, is doing something right now with a big RFP that they just let out for the Washington area. Boeing and eBay have come together to want to contract directly with provider groups in the Reston area. So you do see employers coming together. eBay only has 200 lives there. Boeing is providing the majority of the lives. So you do see employers that will come together either through an entity like an employer coalition or just each other. They know each other in a marketplace and they want to work together to keep their costs down. So and more importantly, I don't really want to focus on costs. It's about keeping the quality and the patient experience up. So you do see that happening. And I think I mentioned, yes, for jumbo employers, Intel did what Disney did in New Mexico because they had a huge number of people in New Mexico. They did this with Presbyterian. GM took our playbook and did this with Henry Ford in Detroit. So you do see the large employers stepping out and doing it because they've got this volume and the leverage in a marketplace. But I think it can be done. And again, it could take on different elements where you as an MSO or a provider group and say, we want to deliver all the orthopedic care in this particular market. Employers want that. They want to be able to deal with one group where they can have a direct conversation with the medical director, with the physicians, where they can talk about what we would like to see for our employees. That might not be the biggest direct deal in the world, but you're going to take all of that orthopedic volume from that employer. Right now here in Southern California, Electronic Arts is in the Marina del Rey area. They have about 7,000 lives there. They're looking to do exactly that. So, it just will take a different form, I guess, depending on those key elements of volume and geographic access to make sure that you're there and you can deliver the care. So it's the big question.
That's from the employer side. There's the size element. What about from the provider side? So it's not an accident. Disney, I don't think that Disney struck a deal with a large health system. So the health system has lots of providers, lots of clinic footprint. I imagine they've got a network of specialists associated with the hospital beyond primary care. So from the provider side, if you're a single specialty MSO, 100 to 1,000 providers, but just orthopedics, just urology, just cardiology, or even just primary care, but you're not a hospital system. Is there a place for you and a strategy for you in the employer market, or is this really a hospital to large employer game that's being played, or strategy that's being executed on?
Gosh, again, such a good question. There's so much going on in the marketplace that's kind of diametrically opposed to doing kind of the good thing. You're seeing so many of these big hospital systems buying physician practices, buying hospitals. I think, what they tell people is, oh, then we can provide the full range of service to you. Not so much. I think they're doing this because they can price however they want to price.
Mhm.
I'll say period, new paragraph. Employers are interested in quality and the patient experience. If you are an MSO or a group, I mean, MSO to me is just relates more to the organization of the group. But let's just say you're a group that has an organization that can contract directly with an employer. If you have enough physicians and a reputation for quality, the employer is happy to direct people to go to you. That is what employers want to do these days. They're tired of the rifle shot where quality is uneven, access is uneven. An employee will try to go to this group and find out, it's a 6-month wait. If you're working directly with a large group, whether it's derm, orthopedics, behavioral health, you're going to strike a deal where you're giving your employees some level of access, where you as the employer can guarantee some type of customer service. And you know that your employee is going to get taken care of. This is as important to the benefits people who are designing these things as anything. So yeah, it depends on having, a group that's large enough that they can handle access for a local employer, the information to say to the employer community, these are our quality metrics. And trust me, employers are not healthcare people necessarily. I mean, you just need to tell them, look, if you're an OB group and your C-section rate is half decent, that's all the employer cares about. So, you're an orthopedic group. Tell them about your infection rates and your redos, and you have the employer ready, handing you a piece of paper to sign. So employers are desperate to find higher quality care and a better patient experience. And, I think not every group out there can do that. And I do think you've got to have the organization, the governance, enough investment in technology to be able to deliver perhaps even virtual care as well as on-site care, or I should say in-person care. Many employers still have on-site clinics that they would like to have a provider be able to staff. And this is the same
Mhm.
provider you could see virtually or you could see in their office. So there's lots of opportunity, but it does take some thought and some organization.
It reminds me of our my former business. GIASCs was our focus, and we had relationships with a number of the Wall Street banks here in New York, where they had on-site clinics, and they were very happy to have a network of GIs, just like you said, with good service, with access that was attentive, that had appointment, quick turnaround times, and they had a lot of patients who presented with either anxiety or stomach issues caused by anxiety. And so they needed a specialist to turn to, and they had the primary care clinic on site, but they didn't have the specialist network. So they were very happy to send their patients our way.
For
But it took
sure.
work. It took work. I mean, we had to go cultivate relationships with these on-site clinic medical directors, and the volume of patients was it varied. It varied.
Yeah, I mean,
So
it can be
would you?
disappointing. I mean, you've got, and I think you're putting your finger on it. You've got to make the commitment. You make the commitment
Yeah.
to doing it. You've got to do the marketing. You've got to go out and talk to these folks. And thank goodness people are coming back to seeing people in person. I mean, you've got to be able to say to them, look, come to my clinic. I mean, you should see what Kaiser does. Kaiser shows up at Disney, takes the executives for a tour of their new medical groups or their new medical offices, gives them a full day of an executive physical. I mean, Kaiser knows that they have a brand that needs some work, but they work it. That's, they have 2 million members here in California, not just for that reason, but for a variety of reasons. But let's talk about the value of doing it. When you see a Medicare patient, you're maybe, and I'm making up these numbers, maybe you're going to get paid 80 cents on the dollar. Heaven forbid you're doing Medicaid, and maybe you're going to get 50 cents on the dollar. When you bill me, you are getting $1.20 if I'm lucky. Stanford gets $1.80. I mean, this is really a way for you to maximize your revenue outside of government systems. There are three buckets of money in healthcare, Medicare, and they're all about even. They're all like 30, 33, well, a little bit, whatever, but Medicare, Medicaid, and commercial. And then a small smidgen, which is out of pocket, direct to consumer. I mean, work with the people and I think a commercial understands we are supporting providers that are Medicare and Medicaid. And we're kind of happy to do it as long as it's somewhat reasonable and not 800% of Medicare. But this is where you can make money. And I think, frankly, the patients you're seeing, these are commercial lives, typically well under 60 years old. These are people that are working. You probably need to have mental health people on staff.
Mhm.
You need to have people that can be seen, be able to take care of people during working hours and after work. So yeah, I mean, it's a different product. It's a different avenue for revenue, but it's a good one.
You mentioned that there are in Silicon Valley, there are groups that are coming together and then going to create these kind of pooled pools of employees. Is there the same concept on the provider side? So instead of approaching employers as just an orthopedic group or just a cardiology group, there are people that are bringing together non-hospital based large high quality provider groups to then approach either these employers and or these other aggregators of employers.
You're getting to something that's happening out in the marketplace today, and it's not provider groups that are doing this, but outside entities, typically PE backed, who are going out and accumulating these various specialties, then offering that to an employer. So
Mhm.
you have Carum, you have, oh gosh, it's the guy who built Livongo has got, a new product where he is going out and getting all of his little specialties put together under one umbrella and then offering that to the employer. And they are taking, 20% off the top, probably even a little more than the carriers do when they're doing that same kind of aggregation, if you will, of a network.
Mhm.
I wish, I would love to see more provider entities that would come
Yep.
together and put together the specialists that are needed in a particular marketplace. But you're not seeing that. I mean, unless you have somebody like, I don't know, Healthcare Partners who is big enough that they can actually hire and have in-house specialists, I guess. I don't know. Are
Well,
you seeing any of that among your
Well, I was
provider?
just going to say, I think people spend a lot of time thinking about their payer contracts. The
Mhm,
employer is not a concept that I see come up too often. There are
mhm,
exceptions to that, but
mhm.
it's sort of a step removed from what most providers are thinking about. Obviously, the employers are, dealing with the payers, but I think we're on the provider side typically thinking about the payer. So this conversation is enlightening and changing sort of the view of who's the stakeholder that matters, and you've got two, and you can work with the payers to get to the employers, or you can work directly. So I think that is interesting. I want to show one or two more graphs just from a
Yeah.
market context perspective in the time we have remaining. So I thought this was interesting. It's just looking at the number of members, so the market size for the self-insured versus the
Mhm,
fully
mhm,
insured, and
mhm,
it shows relative stability. A slight
mhm,
decline
mhm,
in the fully insured over the past 5 years, slight
mhm.
growth in the self-insured market, which represents the majority of the market. And so it's consistent with what I've heard, which is relative stability in this market. Do you expect that to
Mhm,
change? Do
mhm.
you expect to see a continued gradual decline of the fully insured, or are these about steady state levels that we should expect to prevail?
Yeah, I think that, the growth engine in this country are small employers. And
Mhm.
when you're, certain size, you just can't take the risk. You're gonna be fully insured. And I think that you'll always see, that number just continuing to, catch up with those that grow enough to become self-funded. I mean,
Mhm.
when you've got a small employer, and I don't know what the percentages of people now that could get up to 1,000 lives, for example, that most actuaries think is the threshold where you could become self-funded. Um, it- for those companies that have that great growth take over, the number that are just coming and starting into business. So I think you're going to see, relative stability here. Self-funding, though, is very appealing for a couple of reasons. One, you don't have to pay a premium tax. And two, you could structure your benefit design however you want it. So you can say, hey, for orthopedic care, we are going to make it free to employees because we want you to go over here. So there's a lot of flexibility when you become self-funded. On the other hand, if it is a hard stop loss market, and you need stop loss. At a certain size, you no longer need stop loss. We never had to purchase stop loss, thank goodness. We were, big enough. Then, the math starts not being as, appealing. But this idea of the flexibility to do what you want to do is really appealing to employers because look, ESPN, men. We may not need to have a really robust, I don't know, whatever. I mean, I want to say maternity, but there were huge maternity there. But, we could design the plan that fits your employee population, again, to make that productive workforce. So self-funding is just really appealing. You're going to have CEOs, though, who are very opposed to the risk and want to stay fully insured and take the rates. I mean, it's so much more expensive to be in a fully insured plan. They are adding the carriers so much to that book of business. But let's look at that next slide before we run
This
out of
one,
time.
yeah. So I think you'll have a lot to say on this. So this is about how employers are responding to cost increases, and 81%. So the biggest sort of response to that is to pass through more cost to the employee.
Yeah.
And I look, I think passing through cost and having a cost exposure is, potentially a solution, right? You could see how it could be a tool. But it's interesting because you spoke about sort of removing barriers to access under the Disney plan in Florida. And so actually in certain cases like behavioral health, making sure that patients could, get as much care as they needed and reducing their personal employee out-of-pocket contribution. So how, if at all, does this resonate with you? Do you see within the Disney model in Orlando was passing through greater cost part of the strategy, part of the reality, or did the model that you created obviate the need for that, or was it counter to your strategy?
Yeah, so I think that your providers will probably have a lot to say about this. When you see your bad debt going up, that is because employers are passing costs back to their employees that the employees just cannot take. The market in the commercial market, the dynamics in the marketplace now are so crazy because of this enormous trend, the 10% trend now that we're seeing, which is, 3 times inflation, outpacing wages by 100%. So because of this big cost trend, employers right now are trying to figure out what levers to push. The feedback they are getting from their employees are that you have cut to the bone. We cannot take more out of our paycheck. And you hear employers talking about this at the various coalition meetings and conferences where they all come together to talk to each other, which is we are not going to be shifting costs as much. So while, cost shifting can take the form of a high deductible plan, which are complete ripoffs, frankly. I mean, this is just resetting the trend. It still keeps going up. Or to have these enormous other deductibles and copays, employees just can't take it. And you find bad debt just skyrocketing of individual employees. You find employees coming to their employers asking for payday loans so they can pay for, and people not getting care because they can't pay the copays. You just start hearing more and more of this. So I think employers are finally saying hopefully turn to the provider community to say, let's partner together on this, because it's also a third rail for labor. I mean, you see the strikes that go on, and it's about we need our stop. We can't afford to pay this much for healthcare benefits. So, but I think for many years, the idea was, just increase. There are only a few things that really will reduce your premium as an employer, and it's primarily the deductible. Keep increasing that deductible, and you can somehow manage your premium costs. But when you feel like the employees are saying you have cut to the bone, you've got to try other things. So that's a perfect slide. It'll be interesting to see it maybe mitigate a little bit next year as people really aren't able to cost shift as much as they've always wanted to.
Look, I want to
So,
thank you. Most of the people we have on this podcast are of technology companies, but the official name is Technology and Innovation. And what you accomplished in the employer market and at Disney specifically is no less innovative than many of the technology companies. So really a fascinating conversation, and really appreciated the insights. Enjoyed learning about what you built at Disney, as well as the broader market perspective on this employer market out there. So thank you so much, Barbara. I really appreciate
oh,
it.
you're welcome. It's been a pleasure.
All
We'll
right,
talk
take care.
again.